So what I would like to share with you this afternoon is not quite what Francesca Saigi said is a model being currently implemented in Europe, but all four of us who are speaking today are working towards being able to bring this model in many countries in Europe. And therefore the announcement of yesterday in your country is one of many impetuses making us do this even more enthusiastically. I think we know this truth that health is a state of physical, mental and social well-being and not merely the absence of disease or infirmity. That is what we know as health professionals and people working in the health system. And that makes us realise that health care is only part of the story. Individual citizens' health depends on much more than what we do to them when they're ill. And that means individual citizens, particularly the elderly or those with chronic conditions, need many other services to help maintain their health. And this will include provision of meals, personal hygiene support, domestic help, help with mobility, help with shopping for food and other essential items like medicines, and importantly social contact so that people are not in a prison in their own homes. So social care in whatever form is essential to complement healthcare. We have today in our society and across Europe 3 pressures for introduction of integrated care. The first set of pressures are the demographic. The increased longevity, people surviving what would a few years ago have been fatal illnesses, coronary conditions, strokes, and serious accidents and injuries, but they are surviving with limitations to their health functioning. This means we have many people with enduring chronic conditions. And at the same time, the pressures on acute care mean that when many citizens have, let's say, surgery or have an accident, the sooner they can go home, the better for everybody, including the health system. We're trying to shorten length of stay. The second set of pressures to add to those are society and consumer expectations. Increasingly, and I think rightly, consumers expect better services than they would have done 10 or 20 years ago. We see this in transport, in retail shopping, in banking, and in many other services. And health should not be at the back of being modern in the way it treats customers of services. We then see the family dispersed in many cities and parts of the country. That families are not living close anymore. They're going away for education, they're going away for work, and they do not necessarily come back to where their older family members are living. And in many countries, we are seeing a reduction in the activities civil society undertakes to its own members. The third set of pressures come from organisations. They are financial pressures, they are pressures within the healthcare organisation, and they are political pressures for modernisation. And quite often they are the strongest driving force because we have instructions or we have a reduced budget. And though the first 2 we have been thinking about, the third one in red makes us act. We are told to act. And that isn't always the best motivation. So what I would like to do is introduce you to a typical older person of Europe in the 21st century. She's called Mary, and she is a real person. A little bit about Mary so we understand her needs. She's aged 79. She lives alone in what has been for many years the family home. She is now the only person living in it. She has arthritis in both her legs and hands, so not least standing in front of the stove to cook a meal is quite difficult for her, so she does not bother. She also has a long-standing digestive problem, so her nutrition will be further compromised if she has a fairly limited range of food. She has a mitral valve leakage, so her general well-being is not that high. And she has small mental lapses, which may be transient ischemic attacks, but she doesn't know she has them, but she will suddenly forget what she's been talking about, or forget that she's put water on the stove to heat. She is what we would call a technophobe. She doesn't like modern technology. So she has a bank card, but she does not use the automatic teller because she doesn't quite understand what happens. So she goes and queues in the bank when it's open. And she has a pendant alarm in case she falls or is taken ill, but she keeps it safe in a cupboard in the house so that she knows where it is when she wants it. She thinks she will know when she's going to fall or be taken ill. She's very sociable. She likes to talk. She never stops talking when you meet her because she seldom meets enough people. But that doesn't mean she does what she's told. She still is independent in her own mind. And I think Mary is typical of many people we know in our daily lives as well as in our professional practice. What's Mary's health support? Well, for all those health needs, a general practitioner is not very interested because he can't cure anything. So he just makes sure she gets her monthly prescription. The cardiologist knows he can do no more than give her medication for the mitral valve. The orthopedic surgeon is undecided what to do about the arthritic knees which stop her walking. The neurologist is unsure what to do with these currently minor transient attacks. The geriatrician, who is supposed to integrate care across the hospital, does little more than try and make all the doctors talk to one another. A home nurse visits once a month. Doesn't do very much because there's not much nursing needed at a particular moment in time. But she does organise respite care for 2 weeks residentially, after which Mary comes back much healthier and much happier because she's been fed properly for 2 weeks, she's had personal hygiene for 2 weeks, she's had some physio and occupational therapy, and above all, she's had company. And after the 2 weeks, she's up here, and then you watch her functioning decline. And there's no health coordination. The family have to broker to sort out between the different agencies what should be happening, including, we think, over-medication, polypharmacy. So Mary has holistic needs for health, not health care needs, but holistic needs of nutrition support, mobility support, shopping support, bathing support, and socialization opportunities. Without all of these, her health will suffer. These are health issues, but they're not tasks of health services. But what about her family? Well, she has no children. Her stepson and her niece are the nearest blood relatives. They each live 90 minutes driving time away, and they both work professionally. So they can't easily call round. She has 2 sisters, but they're her own age and with similar health problems, and they don't drive motor vehicles. Hospitals often say, get the neighbours to look after her. Each side, the neighbours are elderly couples because this is an area where everybody is growing older. Each side of her, the house each side, each husband has active cancer. Which one of those do you ask to also look after Mary? A difficult choice. So who manages her health? Her health is seriously compromised if it's not helped holistically. Healthcare and social care need harmonising. Neither knows what the other is doing, let alone when they are doing it. And the family carers' own situations need to be taken into account with their own personal dependency factors. But in any healthcare system's terms and any politician's terms, Mary is fit for independent living. She's fit to live alone. But there are potential major risks. And disease monitoring, which is coming in through telemedicine, is not the answer. She hasn't got a single disease, a single chronic disease, that needs monitoring. Mary is a test of modern society. How do we handle the millions of Marys living in our countries in Europe, other than badly? All the services are there, but proliferation of those services and how to find them and how to link with them and how to coordinate when they come to help you is beyond a person like Mary. She has difficulty with the telephone and she doesn't know who to ring, who is in charge, what she's eligible for. So to the politician, to the health manager, the answer is there, and to Mary, the answer could be in another country speaking another language. The individual organisations we've talked about are there. They each have organised services and they see themselves serving that big population. But for Mary, as an individual, to them she's just one of the mass. With modern health technology, that's exactly the same picture. We've simply put Mary in the middle. And the organisations are individually supporting Mary. That hasn't happened yet. But with the IT in our hospitals, primary care, and hopefully soon in social care, we can deliver that if only we get ourselves organised. And I'll come back to some of the challenges in a moment. But I want to tell you a little story which seems quite different. I live in Ireland, and we had a friend stay 2 weeks ago who said, I have been to a lovely town in Italy, and you ought to go there because it's beautiful, it's a nice place, it's friendly, but it's not a tourist town. And she was so enthusiastic. When she had left, I went to my computer, opened Google Maps, and typed in 3 words, which you probably can't read there. It's Montecatini-Terme, Italy. It's the name of the town. That was all I did. And what happened? I get a map showing me where in Italy this place is that I've never heard of. I press a button and I'm brought into a close street map. That doesn't tell me much. I click one option, which is up in the top right-hand corner, and there are all the pictures anybody has posted about that town. And I can click on any of those and open them instantly. But I know that people only put nice pictures, attractive pictures, when they post to the internet. They don't put pictures of slums or litter or other things that you don't want to visit as a tourist. So, I recruit my little friend up here. And what does my little friend do online? He lets me stand on any street corner in Montecatini-Terme, which I'd never heard of 5 minutes earlier. And not the picture that that avatar has selected. I can drag the image, I can go for a walk through any street in that town. I can stand on the spot, I can turn round, I can go down one road, I can go down another. I'm in charge in looking at pictures which are no more than probably 12 months old. So I'm in charge of virtual visits to that town. Sorry, we've hit it. Yeah. Escape. Okay, we're off, yes, okay. So on that street map, I noticed the symbol for a railway station. I thought, maybe it's worth going there, but it's a long way away. What's the train service like? Real time, there were the next 6 trains leaving that station the day I looked. But that doesn't tell me that much, because I'm not going that afternoon, and certainly not leaving, I'm trying to get there. So there's a link. I click on that link, straight into the Italian Railways website in my own language. Okay, that sounds reasonable. I noticed also by the railway station a bus stop sign. I click on that, and there are the bus routes serving that bus stop. Not much use because I don't know where those buses are going. But another link, and there are the bus routes. I can see where I can go to, or how I can get to that station. And just to prove it, I can find a picture of the bus stop, and if I walk up the road to there, there's the picture of the railway station. That looks a bit scruffy. Maybe the service isn't that good. What about driving? On the map at the top left-hand corner, there had been get directions. I clicked on get directions for driving, and there you are. 2 different routes. I'm told how long it will take, and I'm told that one route is 1 hour shorter than the other. And that happened quicker than I'm describing it to you now. Compare what I've just discovered about Montecatini Terme in Italy with what Mary knows about her own services in her own town, provided by her taxes and her fellow citizens' taxes in that city. And you'll agree, I think, that the contrast is pretty appalling. We can find out about this bus service to any town in Europe, and Mary can't find out if she can get chiropody or when they will come when they've said, yes, okay, we'll visit you. We have to redress this imbalance in how we apply not leading technology, but fairly basic technology by managing the information and its access. There was an option which said walking route. I thought I'll try that. And no, I can't walk on water. And this is where you find that Google isn't that clever, because the instructions to the system were fine. If there's water in the way, catch a ferry. And that is a map of the ferry routes, which would get me via Barcelona, interestingly, to Montecatini Terme. So that wasn't an intelligent use of technology, but it was a correct use of the instructions the system had been given. The third option, public transport, I got a message back saying we cannot integrate the different systems for this particular journey, which is a correct answer, even though it's not helpful. But I can go and find it another way. So to come back to Mary, this is what happens at the moment. This is how we traditionally see the health sector. A hierarchy between primary care and secondary care and tertiary care. But that's the citizens' map of their society and their life, which has nothing to do with hierarchies of hospitals and healthcare. It's about family, informal neighbours and carers, and community groups such as church groups, interest groups amongst the elderly. We speak different languages, but we don't Google, we don't link them together. They just touch one another, and the citizen has to be grateful for what they learn and grateful for the access they get. And if we put social care in, that's a different and parallel world, where the services are there, but the communication again is minimal. And of course, housing and ambient assisted living monitoring are vitally important as new services. Education is an important service and underestimated. So it's not a very healthy picture when you compare it with what Google were doing. The answer from the European Commission, and rightly in many ways, is interoperability. But what does interoperability bring as the European Commission sees it? It links health agencies. But what we want to see is it integrating all services around care, with common care aims and care plans, so that it's not what is health doing for Mary, what is social care doing for Mary, oh, and the neighbours can work out their own rota. We should hopefully be able to say, this is what we as a virtual team are doing for Mary. And comparing diaries and schedules, communicating, and using common terms between one another as we do that. My vision, the vision of those of us who are sharing with you today, is to empower the citizen in Europe. Not be kind to them in our own professional ways, but empower them to enjoy their last days of life. Currently in the European Commission's work on interoperability, they are looking at international interoperability. For instance, the Danish citizen on holiday in Greece who loses his medication and needs a new prescription. How can he get that? And that raises technical issues of communicating the prescription, It raises issues of health practice and drugs and dosages and who can prescribe what on what kind of signature. And there are many complex organisational issues. Important, but not, in my view, anything like as important as local integration, where we get a lot of Marys and we need to link healthcare for seamless care and we need to link social care as well. The benefits there for local interoperability would be much, much greater in terms of human gain and payback. Because we know what's out there. There's a person surrounded by services, all of which have data sets and data systems. And those are the obvious ones, and you will have them in this city, and every city in Europe will have them. But they don't work like that. We have, and this is an abbreviation of something that is published, we know the different types of data each of those have, and the data themselves are of a different nature. And the record keeping is of a different nature. But they're all about the same citizen. And those sets of data are largely separate, so that one user, one provider of services, has very little knowledge of what's in the other records. To coordinate that further, there are challenges. And the four major ones, in my view, are, firstly, there's usually a different legal and funding framework for healthcare, to that for social care, and the family, of course, isn't involved in any of that, and different voluntary agencies and non-governmental bodies have their own arrangements. So we're talking about different entities in the same community. Secondly, the records themselves are different. Healthcare records, as we all know, are very deep with a huge amount of biological data, images, diagnoses, diagnostic information, and plans. Care records are very different. They're quite shallow. They say Mary needs help with the following things. But they have a lot of information, rightly, about third parties, about what the neighbours can do. If Mary had a husband, they would probably list what the husband could do in terms of daily health and what he couldn't do, or vice versa for a wife. So merging those simply is not an option. They work differently. They have to work differently. Then thirdly, there are different attitudes to sharing a record. Nobody can see a health record. Usually the patient can't even see it. But when it comes to social care, there is a degree of working together to say, this is what we will do, this is what we'd like you to do. And we need new paradigms of delivery coordination. If you work in a factory, you have, in many cases, what's known as just-in-time delivery of components, or of, in a retail store, deliveries just before stocks run out. We need to do the same in healthcare delivery. There are a number of informatics challenges. I won't read this long list out. They're technical, they are known, they're published, but we're not giving priority to acting on them. Thirdly, we have to make sure that society and the governance arrangements are strong. We don't want everybody to see everything, but we do want some people to see a lot more. We have to have rules for that. They need developing. And then we need to educate the public and the individual organisations on those rules. What we need to be doing is putting the patient at the centre and making that the philosophy, not the service delivery by the individual service. We need to be able to search and select other data when it's needed, and only the single items that are needed. So when is the home carer going in? We don't want that to necessarily be the time the nurse is going in to give a bed bath. They're incompatible, but there's no need to know more than that. Put them on different afternoons. And to think of the patient diary as a key concept. What I showed you from Google, I don't want to copy the Google technology, but I do want to copy the Google mindset. If it's there, find it and use it. It's as simple as that. So in treating Mary, or the many millions of Marys and Josephs in our society, what are the key issues? Who's involved in, and in what way? Who knows what? What should we observe? Who do we contact if we spot a problem with Mary? If we don't think she's eaten for 2 or 3 days, or if she's suddenly looking cold and shaky, and you take in the hot meal because you're the person delivering meals, but you're not responsible for her physical health, who do you contact? Do you know? You ought to know, but we don't empower people to know or act. Yet they are the observers of the health state, even though they're not health workers. We want to ensure a truly holistic view. And in the Google mindset, we should grab the information that's there as long as we do it ethically. And as we start to grow those systems, they will strengthen. So I want to bring in 3 new views on the new paradigm. The first one is to put the patient as centre and coordinate all care delivery. We can use broker technologies which go and hunt for data across systems according to very strict rules, and to put a professional helping the patient set up their own preferences for their delivery of care, thinking of time as a resource in a way we don't at the moment. So the second thing is to bring in time resource management, as happens with airlines and airline crews and many other service industries. But we don't in anything like the same way when we set a care plan and say, we'd like these other agencies involved and other aspects of health. Are they available? And what times are they available? And we can give Mary a weekly or monthly schedule. We don't work like that. But Mary works like that. And Mary's the person we're looking after. Thirdly, we need to bring in specific access control. Who can see what by their role, including what can they see from other agencies' records when they need to, in bringing together holistic and integrated care for Mary. And Mary, with her help from a family member or one health professional, should be able to contribute to setting up that template. Who is she happy to see certain items of information? Who does she want contacted in an emergency? This means we need a new research and development paradigm. This isn't medical research, and it's not ICT research. So in today's European society, it's nobody's research. We need to see this as a recognised key area of research, the organisation of care delivery. We need to move forward to bring about the vision we're talking about. We're not alone in looking at this. I'll pass through this quickly because but OECD and the US National Science Foundation are both looking at smarter health systems, and just highlighted there are a couple of the things they say need doing, including actions to build a smarter healthcare system. So OECD is giving this the top level come on, and the European Science Foundation is also saying this is a research agenda for the future. Because this is the vision we all share, and this has been shared with the OECD and European Science Foundation work. We want all those different agencies, which are in our current society and in our current systems, to come together to enable, we want them to come together to, through e-enablement, to give integrated personal care for Mary. So there are the services all acting independently. What we need to research is those links of data sharing both ways, so that Mary feeds back what works and what doesn't. We need to bring in consent models, and we need rules of governance. So the IT is simple, the organisational part is complex, and the governance part needs consultation. So to conclude, the vision I'm sharing with you, which I believe is achievable, it just needs the societal will to do it, is to give Mary integrated care which is safe, ensures that she doesn't have the risks in her own home she currently has. It's purposeful, we all know what we're doing to support Mary, how long she can live at home, when we start to prepare her for residential care, such as by making sure her daycare is in the centre, attached to where we hope she will go to live in the next stage of her life. That it's communicated between the delivery agencies so that we work to one story, that it's respectful. It's respectful of Mary as a person, not a subject of care, but a citizen with dignity. That is respectful of the staff that look after her, the informal carers that have to give their own time, and her family who may be very worried but just physically can't get to see her every day. We need to make sure that it's equitable, that there is no digital divide or income divide, that this is only available to some citizens and not others. We need to make sure that it's ethical in all aspects, and we need to make sure that it's built on shared information, because all that information is there. 80% of it is locked into health and social care and other systems. 20% of it is known to Mary. What she likes, when she likes to get up, what kind of food she would like. Would she prefer to go out to eat in a restaurant occasionally and we pay for the taxi, or have the meal brought to her? Let's listen to Mary, because she knows. And if we share that information, life, I think, will be a lot better for Mary. It'll also be a lot more rewarding and efficient for the service providers. Thank you.